Welcome to QI Connect, our fourth session for 2020 and the 62nd session since we began. QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the field of improvement, innovation and integration. So welcome to QI Connect. Next slide, please. This is our second session in Microsoft Teams live events. So I'm now going to pass you over to Jess to tell you how it works and how to use the Q&A function to submit your questions for our speaker today, Andrew Gumley.
Thank you very much, Ruth. So just some housekeeping notes to get us started. So you will not be able to use your mic or camera in a live event, but you will be able to see and hear the presenters. At present, it is not possible to interact with other attendees via chat, but what you can do is you can upvote any submitted questions you'd particularly like to see put to the speaker. So please use the Q&A function to submit your questions for the speaker. These will need to be moderated, so it may take a minute or two for your question to show up in the live chat. And this session will be recorded, and by taking part, you consent to this. Next slide, please. Okay, so the Q&A function, if you look at the top right hand corner of your screen, it's the speech bubble with the question mark in it, and you click on that, it will bring the Q&A panel up. Next slide, please. And you can submit your questions using the text box shown. When you've submitted your questions, it will appear in your My Questions tab, and once it's been approved by a moderator, it will show up in the featured panel. Next slide, please. And as you can see, you can also like your favourite questions to make them rise up in the Q&A view for the chair. And as ever, a recording and resources will be made available after the session. Thanks.
Thank you, Jess. Thank you, Jess. So I should have introduced myself at the beginning. Apologies. My name is Ruth Glassborough. I'm the Director of Improvement at Healthcare Improvement Scotland, and it's my privilege to chair this session of QI Connect today. And to highlight to you that as well as staff across health and care services in Scotland, we now have over 1,300 organisations linking in to QI Connect, and this includes 89 universities and colleges. Next slide, please. So some of these organisations are based in other countries. We now have 65 countries represented in our QI Connect community. Due to the time differences, some of them will be watching this via the recording. And for those of you who are joining in person, please do feel free to flag when asking a question where you're joining us from. It's lovely to hear when we have individuals joining us internationally. Next slide, please. So delivering QI Connect is very much a team effort, and what an amazing team it is. So a big shout out to the QI Connect team today. Thank you. Next slide, please. And please remember to tweet as you learn and to use the QI Connect hashtag and tag in @ConnectQI, and do give us a follow if you're not already following us. Next slide, please. So I'm delighted today to introduce our guest speaker, Professor Andrew Gumley, who is Professor of Psychological Therapy at the University of Glasgow, and he's also Chair of the Scottish Government's COVID-19 Mental Health Research Advisory Group. Andrew is a leading international researcher investigating psychological interventions for individuals experiencing psychosis. And he's been at the forefront of developing and piloting interventions for psychosis, including ones such as compassion-focused therapy and acceptance and commitment therapy. More recently, Andrew has played a key role in understanding the mental health impacts of COVID-19 at both a population level and on health and care staff. So today he's going to share with us some of the evidence around the impact of COVID-19 internationally on mental well-being, and then more specifically at a Scotland-wide level. He's also going to share some of the evolving responses within Scotland, which I'm sure will also be of relevance to our international audience. And given his passion for involving individuals with a lived experience of mental health issues in his work, I'm sure we'll also hear a bit about that. So Microsoft Teams Live doesn't yet have a functionality for you to make comments, but you can use the Q&A box to share examples of responses within your countries that you feel would be useful to highlight. So as Andrew is talking today, if you think we're doing something in our area that I'd like to share with the wider QI Connect community, please do submit that via the Q&A box. And what we will do is we'll collate these afterwards and we'll share them on our website. So with no further ado, it's my pleasure now to hand you over to Andrew.
Ruth, thank you very, very much for such a kind introduction. It's such a pleasure and it's a privilege to be here today. And I just want to start by thanking the team at Health Improvement Scotland and QI Connect for all the support and organising of the talk today, and particularly to add my thanks to Jess as well. Next slide, please. You know, I don't feel that I have any great expertise, but I do know that there are very many people here today who do have very significant and expertise and experience in responding to COVID and its mental health impacts. I think one of my jobs today is to tell the story of the mental health impacts of COVID, and you know, it's not a happy story to tell, and it's important to acknowledge and appreciate that today. And I just wanted to really acknowledge and thank so many people who are here today who have very much been at the forefront of responding to COVID or responding to the consequences of COVID, and also, you know, to thank Ray D'Souza, who's here today, who's shared some really useful resources via the website promise.scot and via the National Wellbeing Hub, where there's resources around feeling good and Sleepio, and also ideas around responding to your team, responding to supporting your team. And I know that those resources will be made available in the resource pack. Next slide, please. So my talk is in two parts today, really. The first part is really to talk about the growing evidence base of the mental health impacts of COVID, and to really you know, pay tribute to the scientific expertise and cooperation since March and before March 2020, you know, towards working towards greater understandings and a greater appreciation of those impacts. The second part of my talk will really talk about how we've responded to the pandemic in Scotland in terms of mental health impacts, and particularly I'll describe my experiences in working with colleagues in the university, in universities, in the Scottish Government, in the NHS, in public health, and also those with lived experiences where, you know, it's been a privilege to be part of a broader group with a broad range of expertise and a broad range of experience that people have very readily shared and very readily contributed to making sense of the evidence as it emerges and translating this for policy. And I particularly wanted to thank Dr. John Mitchell, who was Principal Medical Officer at the time we started this work, who put a lot of energy into this work. Next slide, please. So thinking back to March 2020, what did we know at that time? And truth be told, I don't think any of us could have fully appreciated where we were and what was really about to happen. I remember myself looking at the literature and looking to find out if there was any clues about COVID, and particularly around the mental health impacts of COVID. And I came across a very important and very significant literature on the SARS virus, which was during 2002 to 2004, where over 8,000 people from 29 different countries and territories experienced infection, and at least 774 died worldwide. That literature told of very significant psychosocial impacts, beginning with those individuals themselves who survived the SARS virus, and there was certainly evidence of increased rates of psychological distress, and also increased rates of anxiety and depression, and particularly increased rates of post-traumatic stress disorder that seemed to be linked to the kind of fears and concerns about the consequences and the mortality consequences of the SARS virus. The other signal that came from that literature was the impacts on healthcare staff who were working with SARS patients, and the impacts on those individuals in terms of impacts on sleep and mood and anxiety, but also impacts on also traumatic impacts in terms of the experience of nursing or working with those patients. And thirdly, and more broadly, there was evidence of impacts on the general population with increased anxiety and worry about infections, but also some evidence of increased rates of suicide from studies in Hong Kong, particularly amongst elderly people. Next slide, please. So we can think about impacts of COVID-19 as they radiate and as they radiate outwards, and we can think about those impacts on individuals themselves who've experienced COVID and particularly experienced admission to hospital and ITU, the impact on healthcare workers and other staff and others who provide support for those survivors of COVID, and then also more broadly impacts on the general population, including other specific populations. Next slide, please. So as you can see from this slide here that since March, there has been an exponential increase in the number of publications of studies that have investigated the mental health impacts of COVID. And this is since the 4th of March, 2020. And this evidence is taken from the Evidence for Policy and Practice Information Coordinating Centre, who retain weekly updates on the COVID-19 literature, not just in terms of mental health impacts, but right across the literature. And this graph has been created from tracking the mental health papers that have been published since then. This demonstrates two important things. Firstly is just the immense effort across the globe of researchers and others to document and track and report and synthesize the impacts of COVID. But the other thing that it represents is the real challenge for any individual or any organization or any government trying to synthesize this evidence and make sense of it in a way that can translate directly into policy, and do so in a timely and an efficient way. Next slide, please. So what do we know of the impact of COVID-19, the mental health impact of COVID-19 on patients? Very, very sadly, we know that since the outbreak, over 43.5 million people in 200 countries have been infected with the virus, and of those, over 1 million people have now died worldwide, and those data are taken from the Financial Times coronavirus tracker as of the 27th of October. There has been a very important systematic review that was published on the 18th of August it was published on the 2nd of October 2020. And this was the systematic review carried out by Deng and colleagues, and this reviewed all studies that had investigated the prevalence of depression, anxiety and sleep disturbances in patients with the COVID virus, and included studies up until the 18th of August 2020. And most of these studies, so there's 31 studies in all, but most of these studies were rated as having a low risk of bias. The next slide, please. So for these studies, the pooled prevalence of depression amongst COVID survivors was 45%, anxiety was 47%, and sleep disturbance was 34%. So in patients who survived the coronavirus, and most of these patients are people who have been inpatients and since discharged, rates of psychological distress are high. Depression, anxiety and sleep problems tended to be higher in women. They also tended to be higher in those who had more severe infections, but also amongst people who are more fearful of discrimination as a result of having a COVID infection, rates of distress were also higher. Those who had childcare responsibilities and those who had an infected family member also tended to report higher rates of depression, anxiety and sleep problems. Next slide, please. What of the impact on staff caring for COVID-19 patients? We have data from a wonderful living systematic review of the mental health impacts on clinical staff dealing with epidemics and pandemics. So this includes more than COVID-19, but includes a range of other high-risk infectious diseases, including Ebola, H1N1, MERS, and also SARS that I've mentioned already. This systematic review was published in May 2020 and was updated as recently as the 8th of October this month. And at that stage, there were a total of 27 studies that had investigated the impacts of COVID-19, the mental health impacts of COVID-19 on staff. And these are all quantitative studies. Next slide, please. In terms of findings, the first thing to note is that different studies use different measures and not only just use different measures, but also use different cutoffs. So it's difficult to estimate with absolute precision rates of psychological distress, but what we do see is a range for anxiety and depression and post-traumatic stress disorder, which demonstrates very significant and important impacts on staff. The first thing that we see from these studies is that those staff who are really at the forefront, who are working in high exposure and high intensity environments, have much higher risk of psychological distress and much higher ratings of distress on these measures. We know that staff who have previous experience of psychological distress are more likely to experience distress in response to COVID. But also we know that when staff with experience of seeing colleagues infected or being worried about infecting colleagues and family, those staff who are, feel a lack of support from friends, family and organisations, and staff exposed to greater stigma and greater discrimination, and also staff who are less trusting in their PPE equipment, all tend to report higher rates of distress. Importantly, where staff have access to active coping strategies such as exercise or planning or problem solving, where they have support from colleagues and from others, where they have access to good training and access to good protective equipment, we also know that those staff seem to be protected against some of the psychological consequences and psychological impacts. It's also important to note that while psychological support is valued generally by staff, there is some evidence to suggest that those staff experiencing the most stress in relation to COVID are less likely to seek help in relation to that. Next slide, please. These are data from another systematic review. So this was a systematic review, again, published this year in 2020, which included 117 studies. And again, this cuts across a range of viral epidemic outbreaks. What's important about this review is that it shows that those impacts on staff are not transient at the time of the epidemic or the pandemic, but after the epidemic and after the pandemic, these effects remain stable or may increase for some staff over time. And I think this is an important message that we bear in mind for when our own pandemic recedes, that we continue to support staff in the aftermath of that. Next slide, please. So what of the general population impacts? There's another recent meta-analysis of 50 studies. Now this meta-analysis includes studies of the general population, of staff and of COVID patients. Again, it focuses on quantitative studies using validated measures of stress, anxiety and sleep and depression and post-traumatic stress disorder. But what we see in these studies in the general population are high rates of psychological distress in the general population. And I thought I'd like to point towards another project, the Depressed D project, which is a living systematic review of the mental health impacts of COVID on the general population. And that's a live review and it's ongoing, and we'll provide a link to that project in the pack provided with this, but this will produce important evidence on those impacts on the general population over time in the future. Next slide, please. So many of the studies are very mixed in terms of their quality and in terms of their representativeness. And what I wanted to do for this talk was really focus on high quality studies that have national and representative samples. And there are a number of these that have been published from the US, from the UK and from Hong Kong. And all of these studies show increased rates from pre-pandemic to during the pandemic in terms of rates of depression and anxiety, rates of psychological distress, acute stress, and indeed increased rates of suicidal thinking. The evidence is becoming clear that young people, women, those with pre-existing mental and physical health problems, those from more disadvantaged backgrounds, and those who have experienced greater insecurity, so insecurity of food, insecurity of income, insecurity of occupation. Individuals who are exposed to much more contradictory media around the advice on how to respond to COVID. And those experiencing greater restrictions in their mobility seem to be more adversely affected. Next slide, please. I wanted to make mention of a very recent study, and this was published last week in the British Journal of Psychiatry by Rory O'Connor and his colleagues. And this is a recent study of the first 6 weeks of the UK lockdown. So this is during March, April and May. And this study found that those from more socially disadvantaged backgrounds and those individuals with pre-existing mental health conditions reported the worst mental health outcomes across all indicators. And in particular, people with pre-existing mental health problems had very significantly higher levels of depression and higher levels of anxiety. And younger adults also reported the worst outcomes compared to any other age group. And you can see there evidence of increased rates of anxiety, depression, and indeed suicidal ideation. Next slide, please. I think what these data say is one very, very important thing. Since March, we've all been going through the same storm, but we're not all in the same boats. We're all in our own boats, and the impacts of COVID, and then particularly the mental health impacts, but also other impacts of COVID, have fallen unevenly right across our populations. What I want to do is now think about my experience of our response to these impacts in Scotland, and how we've tried to make sense of the evidence and translate this evidence and synthesize this evidence and translate it for government. Next slide, please. This time last year, almost to the day, we established something called the Scottish Mental Health Policy and Research Forum. John Mitchell, who was the Principal Medical Officer at the Scottish Government at the time, and I felt that a missing process was a forum where researchers and policymakers could come together to share expertise and to share knowledge. And we began work on putting together this forum. Next slide, please. This work was suspended when the pandemic hit. But right around just shortly after the pandemic, it was John who suggested we should repurpose the forum to a research advisory group. And the purpose of this research advisory group was to act as a central coordinating point for translating and making sense of this evidence, so that we could turn that evidence into advice for government. Next slide, please. And we undertook a series of activities. So we met together, we developed terms of reference, we publish our minutes on the website, and we undertook a number of activities, including surveillance reports in the initial months of the pandemic, and also we conducted a rapid review of the evidence as it was emerging in the early months of the pandemic. Next slide, please. In the early months, we produced 3 evidence briefings, and this work was led by Alex Rosenberg and was extremely helpful to the research advisory group in terms of making sense of the early impacts on mental health in April, May and June. And at that time, what we were seeing was data showing increased levels of anxiety and lower levels of well-being in the UK population. And although anxiety levels peaked and somewhat declined in those months, they still remained high. It was certainly apparent that these impacts were not evenly distributed, and certainly there was evidence that people who were living in poverty and deprivation, people living with long-term conditions, were being more impacted by COVID and by these mitigation strategies. And it was important for us to understand these different impacts on different population groups over time and make sure we communicated that clearly as advice to government, or as evidence to government. Next slide, please. We also identified the need for a rapid review, and this rapid review was led by Public Health Scotland, and I want to acknowledge Emma Hogg, who just gave a huge amount of energy to this work as well. And we asked 3 questions. We asked, what's the impact of the COVID pandemic on mental health outcomes? What are the risk and protective factors? And what are the key learnings and implications for Scotland? Next slide, please. I've already shown the COVID living map of the evidence, and we use this as our way of searching the literature. And we searched the literature for the first 10 weeks of those searches between March and May 2020. We also used a number of other resources to find studies, and we used PsycInfo, and we also used a number of pre-publication databases, medRxiv and SciArchive, to identify relevant papers that would help us synthesize the evidence. And we identified a total of 51 studies. Next slide, please. The first thing is to say the kind of problems that were in the evidence. There were very significant methodological limitations. This is evidence that was in the early stage of development. And of course, as evidence emerges at an early stage, we're likely to see more methodological problems in sampling, people having different measures for different outcomes and different tools. There's maybe gaps in analysis, and some studies aren't necessarily well described or reported. And for example, there were very many studies that were conducted with what are called convenience samples. So these are studies that are conducted over social media, for example. And these limitations meant that we were appropriately cautious, and it was difficult to draw very clear conclusions, difficult to generalize to populations, and difficult to compare studies. However, next slide, please. There were some very significant and important observations at that stage. It was very likely that we were going to see an increase in poor mental health in Scotland. It was very likely that this increase in poor mental health was not going to be distributed evenly across the population, and we identified at that stage that frontline staff, women, children and young people, those with less access to educational privileges and opportunities, and people with underlying health conditions, and particularly mental health conditions, were certainly at risk of having greater impacts. And we also identified there were some clear protective factors. So having access to social and family support, having access to good hygiene measures, and also physical activity appeared to safeguard mental health. Next slide, please. The third activity, the Scottish Government funded a Scottish COVID-19, lovingly called SCOVID, mental health tracker study. And these findings are published in this report and are based on data that were collected between the 28th of May and the 21st of June 2020. And this includes a representative sample of over 2,500 adults in Scotland. Next slide, please. This is a busy slide, but there are some key messages here. The first message is that young people aged 18 to 29 years old had significantly higher levels of anxiety and depression symptoms. Those individuals living in lower socioeconomic groups also had higher levels of distress. Individuals with pre-existing mental health problems, and also people of colour, so people from Black and ethnic minority communities also seem to be more adversely impacted. Next slide, please. And this slide also shows a similar pattern of findings in terms of evidence for increased suicidal thoughts, where we saw evidence for individuals who were younger, living in lower socioeconomic groups, those with pre-existing mental health problems, and those from minority, Black and ethnic communities being at higher risk of having mental health impacts. Next slide, please. So what of translation and translation of this evidence? There's two things that I wanted to make reference to. The first impact, or the first translation of this evidence, was on our mental health transition and recovery plan that was published earlier this month. And in the mental health transition and recovery plan, Scottish Government have signalled these impacts and inequalities are key aspects of this strategy. And this will help us think about and move towards the development of the mental health strategy in 2021. The other important translation to policy and practice has been with regards to the National Wellbeing Hub. Next slide, please. The National Wellbeing Hub really made very good learning from those earlier and previous outbreaks, and the hub was launched in May 2020, and it was launched as a single platform for health and social care staff, and also for unpaid carers and supporters, to access good quality and high quality resources. It very much reflected the learning from the experience of professionals in other countries dealing with COVID, and also in dealing with other emergencies. Content and resources reflected the concept of psychological first aid, and were governed by a number of principles, including empowerment, self-care and prevention. And also the National Wellbeing Hub provides access to digital mental health resources, including Feeling Good, including Sleepio, and also Daylight as well. Next slide, please. So I want to, suppose, bring what I've spoken about together and mention a number of key messages. The first message is that there's really an extremely rapid increase in mental health research over the pandemic. And that synthesis and translation of evidence to policy needs to be timely and needs to be of high quality to provide a basis for decision making. And I think this is a real challenge, not just for us in Scotland, but also for every country. And I think for us, a key aspect of our approach to evidence synthesis has been to bring together people with different expertise and different experience. So bringing together researchers and clinicians, people with lived experience and policymakers, so that we're bringing diverse knowledge and diverse expertise to this process. Next slide, please. I think in relation to that, I think it's important to think about the discipline of mental health science and the importance right now of needing a kind of broader, inclusive and diverse discipline of mental health science. So that means engaging a range of stakeholders and being involved in the science, not just as participants, but also in terms of helping define the questions and define the outcomes and define the methods. In the evidence that I've talked about today, so much of that evidence is based on quantitative studies, and actually qualitative studies are really important. We need more research that captures the lived experiences, particularly of groups that have been hit hard by the pandemic and have been marginalized by the pandemic and its economic consequences. We need to ask questions not just about what's wrong with you or the negative impacts, but also research that understands strengths and resilience, and not just resilience amongst individuals, but the resilience of groups and communities. And we also need to, and very importantly, assess the impacts of policy changes and changes in services, and the impacts that these have on the determinants of mental ill health and on outcomes for individuals and services. Next slide, please. The mental health impacts of COVID are falling unevenly, and they fall along existing fault lines that are long-standing and that are post-colonial. And these fault lines reflect structural inequalities. I think we have an opportunity to really meaningfully address these impacts and inequalities. And I think if we fail to, those inequalities will be magnified, and that will have potential for further marginalization, but also will have impact for public policy in terms of impacts on trust and public confidence in public health measures. And I think public health policies need to address and mitigate these impacts on those groups who are at greater risk of being subject to those mental health impacts. Next slide, please. And I think finally and importantly, healthcare workers, carers and supporters, not just in the NHS, but in social care and also in other settings, third sector settings, NGOs, voluntary sector settings, have played an absolutely crucial role in responding to the pandemic, and we know that they are at increased risk of distress. There's crucial learning about healthcare, how healthcare systems have responded, and we know that healthcare systems that providing support and supervision and training and optimizing how we support individuals is really important. So we need to think about how to create accessible pathways to support people in their caring roles, and these pathways need to be trauma informed, timely, and evidence based. Final slide, please. I just want to say thank you to a number of individuals. Alistair Cook, who's the Principal Medical Officer in the Mental Health and Social Care Directorate, Ray D'Souza, who's here today, to the Mental Health Research Advisory Group, and also to Catherine O'Hare, who's Research Assistant for the NHS Research Scotland Mental Health Research Network, who's done a lot of work in putting together information for the resource pack and helping the slides today. So thank you.
Thank you, Andrew. That was fantastic, as evidenced by the amount of questions we've had come in. There's some amazing questions being submitted. There's no way we're going to get through all of them today, but thank you, everybody, and please do keep voting on the ones that have been submitted. We are going to start, though, as usual, with our guest questioner's question. Our guest questioner today is David Weekliam, who's the Global Health Programme Director at the Health Service Executive in Ireland. Now, unfortunately, David's been experiencing IT connectivity issues today, so actually wasn't able to link in, but he did send over his question, which I'll ask on his behalf, which is how can governments do better in factoring in the immediate and longer term mental health impact of COVID-19 in deciding the extent of restrictive measures? He's actually snuck a second question in as well, which is what do you think are the best sources of data and evidence for assessing and monitoring mental health impact? But that first element, critical question, how do governments do better when they're thinking about restrictive measures in factoring in mental health impacts?
Thank you very much, Ruth, and thank you very much to David Weekliam. I'm disappointed not to meet David today, and I'm grateful to him for his question. There's a really important issue behind that question, and it is this decision making between on the one hand, we've had to and we'll continue to have to prioritize the control of the disease and the risk on the population in terms of mortality and the risk on the population in terms of overwhelming health systems, and that continues to be an important priority. And I think his question recognizes quite rightly is that when government make policy around those restrictions, that has impacts. It has positive impacts in terms of protecting the population, but it has negative impacts, and one of those negative impacts, obviously that's important today, are negative impacts on social isolation, on domestic violence, stress from loss of income, etc. So I think it's a decision making that's excruciatingly difficult to make, and I think the first thing to say regarding those decisions is for me the first thing that goes back to, in terms of the immediate advice around mitigating the disease itself. There is evidence that where governments are clear, where they deliver advice in a transparent and trustworthy way, and where they involve a range of stakeholders in that, where you get greater perceptions of trust in that advice, that actually results in better mental health outcomes more generally for people. There's evidence that inconsistent advice or contradictory advice can actually increase psychological distress in the population. So actually immediately there's something that we can say about how we deliver advice at that stage. I think we do know, and I think an important part of this presentation today is the government needs to carefully monitor and take account of the evidence of impacts on mental health and include those data and include that information in its policy making and in its policy decision making, and that should be part of a debate, and that should be part of a kind of transparent judgment that's made around factoring those decisions. One thing I've been impressed by in my experience over the pandemic has been a group called the Mental Health Collaborative, and that includes people from stakeholders from a range of contexts, including a range of populations and communities who have been disproportionately impacted by those measures. And the Mental Health Collaborative in Scotland has been an important source of advice and information and experience about those impacts that has helped shape policy and has helped shape the recovery and transition plan for mental health in Scotland. So in terms of the kind of data and the best sources of data, there's research evidence, but there's also evidence from including those groups and including those populations in consultation and decision making. I think the final challenge for us all, and this will be something we need to solve in future months, is how do we track the impact of those policy changes and policy impacts, and how do we track the impact in terms of outcomes for people who are using services, but also how do we track the impact on what we know about the determinants of mental ill health and the determinants of mental health impacts of the COVID pandemic. So I think there are questions still to be answered about that, and I think it'd be really good to hear if people have experiences of that too.
That's great, thank you, Andrew. Just to remind everybody to please keep voting on the questions which you most want to see asked. We're only going to have time for a couple more, and in choosing the questions I will be guided by your votes. We do also have Ray D'Souza joining us today from the Scottish Government, who will be able to answer any specific questions about the Wellbeing Hub, so he may jump in. And also please do use the Q&A to submit any ideas, any examples you have of good practice around responding to the challenges around mental health needs. So the question that has the most votes so far is Chris from Edinburgh, who, Andrew, she's asking, what suggestions do you have around accessing those staff members with high levels of distress who are less likely to access formal supports?
I think that's a great question, and one that I think I'll ask Ray to help with too. But before I do that, I think something that really sort of comes out very strongly in the literature is about the kind of the context of where people are working, and the roles that are played by managers and supervisors in terms of supervising staff and supporting staff, and creating an ethos in working which is normalizing and is accepting that mental health impacts are not something to be ashamed of or feel guilty about. In fact, they're normal and they're understandable responses to abnormal and extremely traumatic circumstances. So I think there's something very important about communicating an ethos of curiosity and acceptance and compassion that allows people and supports people to come forward, and that in people coming forward for support, they're not shamed by that in any way, or that they're not felt that somehow that marks them as different or as separate to other members of the team. But I wonder if Ray would be interested in contributing to that, an answer to that question, that excellent question.
Thanks, Andrew. Yes, I totally agree with what you've just said in terms of one of the really important factors is culture, working the culture within which people work, and that's one of the reasons why we've built the National Wellbeing Hub, and what we try to promote through the National Wellbeing Hub is the concept of psychological first aid, which is a rounded, a very comprehensive, sort of all-encompassing. It isn't just psychological support and getting people to get help and therapeutic help, but it's actually what I, as a worker, as somebody's co-worker, can do to encourage someone to keep well, or if they're struggling, to recognize that they're struggling and to help them, rather than people just have to seek formal sources of help. So psychological first aid, and what we've tried to do through the hub is to actually promote that concept within the workplace, and that's a key factor, if you like, in terms of what the hub is about. It's built around that concept of psychological first aid, accepting the fact that healthcare workers and social care workers are not the easiest. Don't readily put themselves forward for help, because it's just not part of the ethos. They're used to caring for others, and sometimes their needs, they lay their needs to one side. So I think that's one of the issues we're trying to promote through the hub, is care for each other, care for yourself as much as you care for others.
Great, thank you, Andrew and Ray. And if you've not visited the hub, please do. I think we've already put a link in the Q&A. If not, we will, and we'll also ensure links are sent out afterwards with the packs. If we're going to move it on now to the next question, which is about whether or not there has been any research on mental health services using phone and video calls rather than face-to-face appointments, and in particular the research about whether or not phone and video sessions are as effective as face-to-face. Andrew.
Yeah, there's a good colleague of mine at the University of Manchester, Sandra Bucci, has recently published a systematic review looking at precisely this question, and actually the evidence suggests that delivering via digital methods, including telephone, are indeed just as effective as face-to-face. I think it does bring a broader issue around the impacts of this pandemic on delivery and on delivery of care in the NHS, and I think it will transform the way in which we deliver care. And when we come out of this, I would anticipate that a lot more of what we do is digitally based and digitally delivered. And I think that was already coming before the pandemic. And I think that's going to have very important implications for training, and for training all healthcare staff in being able to blend digital or remotely delivered interventions with face-to-face support or with other kind of tools. And I think there's a whole new set of skills and a new set of demands that are going to, I suppose, impact on care staff delivering mental health care. And so that's both a challenge, but it's also an opportunity too.
Great, thank you, Andrew. I think this one might be our last question. What we will look at is whether or not there's any way we can get some answers to some of the other questions. The Q&A box is absolutely rammed with questions, Andrew, some great ones in there. But this one from Claire, I've jumped down a bit because it just takes a slightly different perspective on things. I think it would be interesting to get your perspective on. And Claire in Edinburgh is saying that clearly there has been an overall detrimental effect on mental health during the pandemic. I think that's clear. However, has there been any evidence of any people or groups whose mental health has improved as a result of the restrictions or other changes since March 2020? It's
a really great question, isn't it? And the evidence is a bit patchy and the evidence is a bit limited because, often when you get into decent studies and you try and drill down on differential impacts in different groups, then it's hard to find that evidence. But there is a bit of evidence, both in the literature and I suppose anecdotally as well, is that for some people, at least initially, the pandemic reduced a lot of the demands, a lot of the kind of normative demands that people face in terms of travel, in terms of social interaction, and that for some people they did feel some benefit of not having to face the same demands as that they had pre-pandemic. So there is a little bit of evidence for that, but it's patchy and it's not consistent, but it's a really interesting question and an important one too.
So hopefully maybe one, Andrew, that we'll be able to answer in coming months. We can maybe get some research focused on that.
Do you know what? There are so many important research questions, and that's one of them. So I've made notes there.
Great. I'm so sorry, but that's all we've actually got time for today. And Andrew, that's been amazing. Thank you so much. And also thank you to Ray as well for your input around the questions. And as I said, do visit the hub if you've not been visiting that, the Wellbeing Hub. Also, there is still the opportunity to submit in the Q&A box any examples of actual interventions, good practice that you would like to share from anywhere around the world. Thank you, Andrew. Next slide, please. So please do join us for our final session of 2020, which is with Susie Bailey, who is the Director of Leadership and Organisational Development at the King's Fund. Those of you who know Susie will know that this promises to be another insightful and thought-provoking session, and it's going to be on Thursday, the 26th of November from 3 o'clock to 4 p.m. Next slide, please. And of course, our back catalogue is available for you to watch and enjoy on our website, or you can visit the QI Connect YouTube channel to watch any of our back catalogue. You can enjoy it at any time of the day, any day of the week. So it just leaves me to thank everybody for joining today, and hopefully we will see you next time. Thank you all. Bye.